Hello, everyone. This is Jonathan Marks from ADHD in Adults. We're here to talk about optimizing outcomes for ADHD care and telepsychiatry, especially in these times of COVID. I'm here on the line with two physicians who are quite notable in this area. The first is Greg Mattingly, MD. He's the Associate Clinical Professor of Psychiatry and Psychopharmacology and is an instructor at the Washington University School of Medicine in St. Louis. He's also principal investigator for the Midwest Research Group, and he's on the board of directors of APSARD, the American Professional Society of ADHD and Related Disorders. And with us also is David Goodman. He's an assistant professor of psychiatry and behavioral sciences at Johns Hopkins University School of Medicine. He's the director of the Adult Attention Deficit Disorder Center of Maryland. He's the medical director of Suburban Psychiatric Associates, and he too is on the board of directors for APSARD, the American Professional Society of ADHD and Related Disorders. And APSARD and ADHD in Adults are both co-sponsors of this presentation. So with that, I will turn it over to Greg, and David will come in with your questions. So Greg, I'll turn it over to you.
So hello, everyone. This is Greg Mattingly coming to you from St. Louis, Missouri. We're going to talk tonight about innovations in healthcare. And sometimes, crisis breeds innovation. And so for the last 6 to 7 to 8 weeks, I think many of us have been faced with changes in our practice, changes in our community, changes in our society. But one of the innovations has been the role of telepsychiatry in mental health. But in particular tonight, we're going to focus on telepsychiatry for ADHD care. David, why don't you introduce kind of our topic? David's going to be my co-host and moderator for the evening. And what we want to make sure is this is interactive. Give us your questions. David's going to feed those to me. So please lead off with questions as much as you can. David, go ahead and introduce the topic for tonight.
Well, thanks, Greg. I'm glad that we're sharing this program. And to all of the listeners, if you have not been involved in telepsychiatry at the end of this program, you will be encouraged and given the resources to do that. If you are involved in telepsychiatry, hopefully you'll get some new pearls here as to the insights of what can be gained by seeing our patients who are now staying at home, as well as those who are in areas of the country that might not otherwise have access to care. So Greg is going to cover a broad range of subjects. And again, we encourage your questions as they come up in your head. I know with my ADHD patients, they have to blurt it out. So I encourage you to type them onto your screen in the chat in the question area, and we will get to them. So take it away, Greg.
Okay, let's dive in. So a couple of basics, and this is something that I had never really thought about, but during the COVID pandemic, mental health employees, each and every one of us, each and every one of our clinic staff, our secretaries, our nurses, our psychologists, the physicians, the nurse practitioners that work with us, we are all qualified as essential healthcare workers. We will likely face increased personal and professional stress. I know for me, the stress of running a practice, the stress of a clinic, the stress of keeping my staff safe, keeping my kids safe, keeping myself safe is something that, I wake up in the middle of the night thinking about some nights. So all of us have increased levels of personal and professional stress. And you have to remember it's not only us, but the staff that works for us also is going through increased stress. So each of us may risk being exposed to COVID. Our office sits on the front wing of a mental health hospital. It's a 100-bed mental health hospital. And 2 weeks ago, we had 4 TV news channels show up because there was an outbreak of COVID within our mental health hospital right behind the double doors that lead into our clinic. They had 25 staff, 6 patients that had tested positive over the period of a week. So for my staff, trying to keep them in a spirit of safety, emotional safety, physical safety, teamwork, that's something that all of us may be exposed to. We see patients. We're going to talk tonight about how to use telepsychiatry to decrease that exposure, but even among the staff themselves interacting, we have an increased risk of exposure. Mental health employees are only required to quarantine if they have symptoms of COVID or a confirmed test. So unlike the general population, because we are considered essential healthcare workers, if you have firsthand contact with someone with COVID, that doesn't mean you have to quarantine. That's kind of expected. If you do inpatient psychiatry, if you take care of an adolescent psych service, if you're interacting with staff and one of their family members got positive for COVID, that does not mean you have to quarantine. The only times that we are required to quarantine, and we're expected to, is if we have symptoms of COVID or a confirmed test. They do have precautions though. We should wear masks. We should take personal protection precautions, hand washing, trying to distance. We've expanded our staffing as far as the distance between them. They now have 8 to 10 feet between each staff. We're utilizing offices from some of the therapists that are working from home to put staff that are answering patients' phone calls in so that we have increased personal distance and we take personal precautions. The role then is, how do you use telepsychiatry? Telepsychiatry has allowed my clinic, which is a moderate-sized private clinic, to stay open. But the question is, I didn't use telepsychiatry 2 months ago. I'd always kind of been anti-telemedicine. I'm like, telemedicine is for people that don't want to see their patients. Telemedicine is for people that don't like bonding. I like all of those things. I'll have to say it's changed my perspective. So when we think about how do you use telepsychiatry in your clinic in the past, how do you use it right now in the current? But the real question is going to be, how do we use telepsychiatry in the future? How do we use it going forward with innovations that deliver better healthcare for our patients as we come out of this pandemic? So some things that change and change the face of healthcare in general. So HHS, the director of the OCR, came out and said, we are empowering medical providers to serve patients when they're doing this national public pandemic. We're saying that they can use telemedicine, and under this notice, we're allowing you to use traditionally non-HIPAA compliant platforms. So non-HIPAA compliant platforms would include FaceTime, would include Facebook Messenger, Google Hangout Video, Zoom, Skype. You can now use those to provide telehealth. And most of those were traditionally not HIPAA compliant, so you could not use them. What you may not use though, so you can't use everything. There are some things that are considered social media platforms, not exchange of information platforms. Facebook Live, Twitch, TikTok cannot be used, even during this time of telehealth. So there's a great reference here at the top. The Psychiatric Times published an article on ADHD and telemedicine during COVID. And this is part of what led to our symposium tonight. I'm going to leave all of these slides at ADHDinadults.com. So if you go to ADHDinadults.com, you can see recaps of this video. If you go to APSARD, we're going to have links for it. But I'm going to leave my slide deck behind. And one of the reasons I want to leave my slide deck behind is many of my titles are links to the articles. So in this case, if we look at the article, Psychiatric Times, ADHD and Telemedicine, if you tap on it, it's going to give you a hyperlink that will go right into the article. And here we are. So you can go to these slides, they're embedded, and it talks about ADHD, neuropsychiatric disorders, delivery of services in rural areas. And it's a wonderful article that I used as I was putting together this talk. So what do we now know about the new exemptions due to telehealth? Physicians are now exempt from using the Ryan-Haight Act. The Ryan-Haight Act used to be that you could not start a controlled substance without first having a face-to-face physical contact visit. On March 17th, all of that changed. And March 17th is the day that, and I'm going to quiz you all and see if you can remember it. March 17th was the day that CMS, Centers for Medicare Services, came out and said the Ryan-Haight Act is no longer our national standard. You can now use telemedicine to prescribe during the initial visit a prescription for a controlled substance. So that would include ADHD. The Ryan-Haight Act started in 2008, and it was kind of meant to be a break on the prescription of controlled substances, in particular narcotic pain medicines. They didn't want doctors cross state lines using telemedicine without ever seeing anybody to start prescribing all kinds of controlled substances. Now, during this period of COVID, we can now prescribe if I have a college student with ADHD, if I have somebody who's just returned from university and now they need to see a new physician, I can do a telemedicine appointment with them. And as my first time patient, if I diagnose ADHD or it's continuity of care from a prior provider, I can provide care for them with a controlled substance. During this time of COVID, on March 17th, the Centers for Medicare Services said that for Medicare services, Medicaid services, and all other commercial insurances were instructing you to say that during this time you can use non-HIPAA compliant devices as long as they're truly information exchange. They're supposed to be visual whenever possible. So that would be things like Zoom, Facebook, Doxy. You can use only auditory if there is no other option. So if you have somebody that's rural and they don't have a way to get a telemedicine device during this time, you can actually do an auditory visit. CMS came out and said that this is mandatory for any Medicare provider, any managed Medicare provider, any managed Medicaid provider. So for example, United Healthcare with their version of Medicare Complete, which is the AARP version, they have to follow this policy. Here in St. Louis, Centene, which manages 28 of the Medicaid plans around the country, they have to follow this policy that we can now prescribe a controlled substance as long as we have a telemedicine visit, and we can do that to our patients, and we can use it during some of these other devices such as Zoom, which has traditionally not been HIPAA compliant. The other thing they just did is they waived the 1135 waiver. And the 1135 waiver was a waiver that said you can't do telemedicine across state lines unless you have a license in that other state. Everybody interpreted that slightly differently. And so many people said if you see the initial evaluation of somebody in Missouri, but then they go to school, they go to college at University of Chicago, then me being in St. Louis, I could still follow them. Other people said, no. They're now a Chicago resident. They're not a St. Louis resident. You can't see them. 1135, which is a national waiver, has now been suspended during the COVID pandemic. I'm hoping that will be an ongoing issue. And if you think about with telemedicine, how much sense does it make that somebody who lives in St. Charles, I can see them, but somebody who lives in Alton, which is 2 miles away, because it's in Illinois, I couldn't see them with telemedicine. So the 1135 waiver has really expanded our ability to help take care of people in a period of crisis, and I think help take care of people during transitions, going away to college, moving, maybe spending the weekend at their other parent's house, maybe spending the summer at their grandparents' house. We can still give continuity of care. Okay, this is my trivia quiz. On what date did everything change for the face of telemedicine? And the answer is March 17th, 2020. I'll give you an easy way to remember that. I remember sitting in my office, and on the news came on our national Corona COVID, task force. And the director for the CMS group, she's a lovely Indian woman, she walked up on stage and said, I am suspending the HIPAA requirements for telemedicine. I am suspending the Ryan Haight Act. I am empowering physicians and clinicians to use telemedicine to deliver healthcare across our country where healthcare is needed. The way you're going to remember this date, it was St. Patrick's Day. St. Patrick's Day, March 17th, 2020, was the day that telemedicine was changed in our country. The other thing they came out with on that day was codes that you can use, specific codes. So insurance companies have to reimburse for these codes, and they have to reimburse for them right now on parity with what we got for in-office visits. So these G codes that you stick at the end of your diagnosis allows them to know it's a telemedicine session, but it's reimbursed right now on parity as per the Centers for Medicare Services. Let's go to another, I think, a great reference for everyone. This is APA came out with a telepsychiatry toolkit. I first learned about that from that Psychiatric Times article that I referenced earlier. For anybody that looks at this slide deck, look at the links that I've embedded. Any place it's underlined, it's a link. So the Psychiatric Times article is it's about a 5-minute read, but they said APA has a telepsychiatry toolbook. In this telepsychiatry toolkit, you can go right to the APA, and there it is. There's blogs, there's Be Connected, child and adolescent telepsychiatry, history and background, clinical outcomes. Does this really work? Is this as good as face-to-face visits? They give you the data. So this is a great reference to go to. It's a great resource to go to for the clinicians out there. Okay, let's dive into some of the platforms. There are multiple platforms, probably hundreds, maybe thousands of platforms for telemedicine at this point. This is one of the 2 or 3 that we've been primarily using in my clinic. So it's Doxy, doxy.me, and I'll walk you through some of the reasons that I like Doxy, but also talk you through the reasons I think it's both a good and a bad platform. And David, I don't know, are you using a platform right now for telemedicine, or how are you kind of doing this at this point?
So I'm using what's simple for the non-tech person, which is Zoom. And as soon as we decide what we're going to do with HIPAA compliance, as that comes back on board, we'll have to sort out these different vendors. I think one of the confusing aspects for clinicians is that there are so many vendors now that we have to look at HIPAA compliance, but also the cost involved in licensing. And perhaps you can address that when you speak more.
Yep. So Doxy, one of the reasons we first started looking at it is, just as David said, Doxy's been around for a while. A number of universities like University of Utah and universities have used it. A number of medical healthcare systems have used it. And they have a basic platform that's free. And it's probably kind of a little bit of a come on, like anything that's free, they're hoping you're going to upgrade, but the free platform works pretty okay. We have upgraded in our office. We have a platform that I think has 9 waiting rooms, so 9 different clinicians can have their own separate waiting room. You can personalize your waiting room. And the advantage of Doxy, compared to some of the sites, many of these other sites we'll talk about have it as well, every single platform, including the free one, is HIPAA compliant. So in the future, where things will have to be HIPAA compliant, every Doxy platform, whatever you set up, will be HIPAA compliant, the free one or the upgraded ones. Some of the things I enjoy about Doxy is, first of all, I customize my waiting room. So when a patient goes there, it says, welcome Dr. Mattingly. If they log in as the patient, it says you're in Dr. Mattingly's waiting room. And I can say, I'll be with you in just a moment. Welcome, I look forward to seeing you today. I can customize the words they hear when they tap in. If you look over on the right-hand side, I've expanded the invite. So invite in Doxy allows you to invite your patients to their visit either by email, by their calendar, by sending them a text message or a print. I tend to text my patients. Many of my patients with ADHD, they tend to have iPhones, they're right there, or they have some type of Android or phone device. I can text them the link. They don't have to download an app. They don't have to download anything. They just tap on that link. It brings them right into my waiting room. On the left-hand side in the patient queue, when somebody's waiting, I can see there's 1 patient, 2 patients, 3 patients waiting. It'll say, Dr. Mattingly's waiting for you. He's looking forward to seeing you. It's got my picture there. And I can tap and text them while I'm talking to another patient. Hey, I'll be with you in just a second. I'll be with you in 5 minutes. We're running a little late, and maybe a few minutes till I get with you. And they can text me back a response that's between me and that patient while I'm still seeing somebody on Doxy. And so that's been a nice thing. The other nice thing I like about this platform is it allows you to have file share. So file share allows you right in the visit, and I did it 6 or 7 times a day. I do it every day with patients. It allows you to send over an ADHD rating scale, a PHQ-9. It allows you to send over some psychology links. I send over to my patients a thing on grounding. I sent another one on sleep links. I sat and did grounding with one of my patients on visualize 5 things, hear 4 things. And so it allows you to send those links right during your visit, and a patient can fill out a form and send it back to you right during your visit. So that's been a nice part of this. So pros and cons of Doxy, and I'm not selling anything tonight because I'll give you the pros and cons of a lot of things. First of all, every version of it's HIPAA compliant. It can be purchased in bundles with discounts for larger groups. So once you get to a bundle, I think it's 6 or 7 waiting rooms, you get a discount. And as you get to 10 waiting rooms, you get a bigger discount. I love the concept of having a waiting room. That's the way they bill it. Patients come in, they're in a virtual waiting room. You can ping them right in right away. You can have your waiting room give you a queue. It can send you an email, Josh is in your waiting room, or it can send you a text with a ping where a note pops up that says Josh is in your waiting room. So you know both verbally and visually that somebody is sitting there waiting for you, even if you happen not to be looking at your waiting room at the time. You can customize it and say whatever you'd like to say. Welcome to the Mind and Wellness Center. We'll be with you in just a moment. Anything you want, you can put in your waiting room as far as that, whatever picture you want, whatever wording you want. I love the ability to text and email invitation to the waiting room. So some of the platforms, many of the platforms allow you to email an invitation. This one allows you to text it. And for many of my patients, they don't look at an email till later in the day, but almost everybody's looking at texts that come up. You can do visits with camera on, camera off, microphone on, microphone off. In the future, to get reimbursed, you're probably going to want camera on, but for some of our patients in very rural areas, their internet bandwidth is so bad the camera doesn't connect very well, so you can do it just with the microphone on. It's very user-friendly. It's simple because you don't have to download an app. You don't have to remember a website. You just text them the link. You email them the link. They pop on it, and boom, they're right in your waiting room. It's very user-friendly, both for the clinicians and for the patients. This is going to be one of the things when I talk about innovations in healthcare. It allows you to share files. I've become a big fan of sharing rating scales back and forth during a clinic visit. I want you to follow your PHQ-9. I'd like an MDQ. I'd like an ADHD. I would like to check a resilience scale. I'd like to give you some resources. Here's some videos you can watch as a parent that I think will help you to manage the things you're dealing with your child. Here's some things I'd like to think about with therapy. I'd like to talk about grounding. I'd like to talk about visualization. I'd like to talk about mindfulness. And I will email those, and we'll do. I've done more therapy with telemedicine in the last 2 weeks, last 2 months than I've probably done in the last 2 years. What's the negative of Doxy? If I was going to say what's the negative, the video and audio can sometimes be glitchy. Sometimes there's a hang time between the video and the audio. So what I've learned to do with that is I'll send people the link, but I like to have their phone number. So today I had 2 visits where the audio and the video were lagging a little bit. Video seemed good, the audio was delayed. So I called them on their phone. I talked to them on the phone while I watched them on the video. So I think that's a nice fail-safe to have when you're kind of doing doxy.
Greg, let me interrupt. We've got a question from Dr. Almagor in Canada. He wanted to ask, though, about apprising people of privacy issues and making sure that they're sitting someplace that's quiet and private. I wonder if you advise patients about this, or how do you get them set up so that the visit is optimized in regards to their environment and what they can speak about?
Yep. So Doran, that's a great question. And for anyone who doesn't know, Doran is the past president of CADRA, the Canadian ADHD Association. He's a big fan of digital interventions. So thank you for joining us. You know, that's a great question. So I had visits today with a nurse that was working in the ICU, and she had to pause for a moment and go somewhere quiet and go to a break room where she could be by herself. I had a patient that was working in a factory, and he had to walk outside and find a quiet place to have his visit. So telemedicine allows you to have visits in people's lives, but you do have to think about privacy. You do have to think about what you're speaking about. You have to talk about, you know, do you want this to be on speakerphone versus put on a headset? All of those types of issues. And for example, my nurse who works in an ICU who has ADHD, anxiety, and she has a history of alcohol issues in the past. Instead of saying, how's your drinking? I said, you know, how are you doing with your other issues? And so I think you have to think about that. There is no increased mandatory thing for privacy, but I do remind my patients. And I think when you think about HIPAA, HIPAA's going to be a tricky issue going forward about how do you make sure you use a platform that can't be hacked. Many of our platforms right now are considered HIPAA compliant because it's very hard to hack them, but some of our platforms are less safe. Zoom is one of the ones we're going to talk about next, that Zoom has had some megas where their platforms have been hacked. And Zoom, they tell you and they reassure you that if you buy a bundle of 10 or more platforms, that will be an especially secure group that's HIPAA compliant. But I think we work together with our patients. We make sure they know when they're talking to us that, hey, they're in an environment where they can be heard. That's lovely because you can share. I've done a lot of visits with husbands and wives that have ADHD, kids that have ADHD. I get input from their siblings and their family. But there is increased, you know, exposability. I think, Doran, that's a great question.
Yeah, so and I was asked to ask you this question. I know you have slides, and it's always the balance between getting time to present the material and answering the questions. But Jake asked the question about, you said you file share and send over an ASRS, which is the Adult Self-Report Scale. I actually do a screen share, put the scale up on the screen, and then have the patient answer it. And I can annotate and check off their answers. And then what I'll do is take a copy on my desk and fill in the answers hard copy to file it in the form. Do you have a preference one way or the other about either sending them the file or doing a screen share?
So Jake is another one of our telemedicine kind of experts. I've done both. I'll have to say, I am a big fan of the file share. So I've done both. I've taken screenshots, I've done files, but the file share, it's easy. I've been able to file share with 9-year-olds. I've been able to file share with 65-year-olds. So the way that the Doxy site does it, it's the easiest site that I've seen. And once again, it's not the only site. I'm not here to sell any one site tonight, but those are the advantages I'll see about it. Let me dive into Zoom. Zoom is the other one that's, you know, revolutionized meetings. We've probably all done a Zoom meeting. We've probably all Zoomed a family member. Their platform is not HIPAA compliant unless you get a bundle of 10 or more. The bundle of 10 or more is not crazy expensive. So in the future, I would think about if I use Zoom, you're probably going to go to that platform. When I first learned to use Zoom, I think I went to Dr. Barron's Jake. I asked him a few questions, but I actually watched a couple of YouTube videos, and one of which was a special ed teacher who talked about how to do IEPs during Zoom. It was fascinating. She talked about using a whiteboard. She talked about doing all these types of things. So I think Zoom is the other platform that I like quite a bit these days. If I was saying, what are the Zoom disadvantages? It's only going to be HIPAA compliant if you buy a bundle of 10 or more accounts. It can be purchased in bundles with group discounts for larger groups. Individual accounts are free. So you can start with a free account right now. It's easy to use. And I think many of us have a free Zoom account. You can customize your waiting room. You can put pictures in the background. You can do some really fun things with that. You could do visits with the camera and microphone on or off. So if you have to turn the camera off because of low bandwidth, you can do it. It has a whiteboard function that I know a lot of educators, and I can imagine using for IEPs in the future, where people can go on and draw things together as part of a Zoom chat, which is very nice, where you can share ideas at the same time and brainstorm. Easy to use for large groups. Video and audio, I think is excellent video and audio. So if I say, where does this have the advantage over Doxy? I think their video quality is actually better. That's my experience just having used it. It's not always that way, but there are some times that may just be that Doxy has such high user rate right now that they're a little throttled by the user rate, but Zoom has great video quality. For me, it's been more difficult to share files. You can do, as they just talked about, do screenshots and other things, but that link to share files, I think, is a little more cumbersome. And I have not been able to find a way to text invitations to the waiting room. You can email invitations. So you can email and send them to Facebook and things like that. But texting, so many of my ADHD patients, they live in the world of texting. It's been nice to be able to text, and I have not been able to do that with Zoom. There may be a way in the future, but thus far I've not been able to do it. Another popular platform, obviously, is FaceTime. FaceTime is easy to use for anybody that has an Apple device. Video tends to be very good. You can do it on your phone. You can do it on your computer. We can use it during the COVID issue. So Medicare specifically came out and said FaceTime is okay, but it's not HIPAA compliant. There are some people that are trying to build FaceTime Plus, where they'll loop FaceTime through certain applications to make them HIPAA compliant. But going forward, if you think about 6 months from now, right now the basic FaceTime will not be a HIPAA compliant version. This next is meant to be a reference. And so I gave this, and once again, I'm going to share the slides on ADHD in adults. This is a lot of telemed platforms. It was put together by the group called VC, so you can see their name, they've highlighted it. A lot of our therapists in St. Louis have gone to VC, but it goes through, I think, in a very well-balanced way, pros and cons of all the main telemed platforms up there. So you can see Doxy, you can see Cloud Visit, you can see CarePass, you can see America Well, you can see iPath, eVisit, SiteCall, and they just tell you, why do you want to think about one or the other? Each of these has their own pros and cons. None of them are perfect. And so it kind of walks you through what were the telemed platforms. It also walks you through what are the ones that are cheap, what are the ones that are expensive, what's the cost going to be in particular when you think about it. So David brought up cost. So some of these platforms are free for the basic user. You can set up a basic platform. Some of the therapists in my office, before we set them up for our entire office, that's what they did. The very day we went out, March 17th, St. Patrick's Day, we started using telemedicine. That was the day we started using it. We each at first started doing it in our own way. We're just thinking, we've got to see patients. Patients can't come in. They have a risk of infection. We're trying to keep our staff safe. So what do we do? So we each went to slightly different platforms. We've now consolidated, and we're using 2 different platforms is what we're using. The cost can be from free to hundreds of dollars per month. Our clinic right now for one of the platforms is paying $360 per month, and that gets us either 8 or 9 waiting rooms. So it's a cost. It's not a terrible cost when you think about the cost of doing business, especially shared among 8 to 9 clinicians. I think you have to think about how many waiting rooms your practice is going to have. And once again, the Zoom platform, I like it in a lot of ways, but you need 10 waiting rooms to get to the HIPAA compliant version of it. Otherwise, you have to buy extra waiting rooms over and above what you need. Think about if the telepsychiatry platform is compatible with your EMR system. Most of these are, some of them are not. So for example, if you're using Epic, if you're using NextGen, if you're using a GE version, whatever you're using, you want to think about, what does my EMR system have? Is it going to be compatible or easy to use with this? I would always think about, is my thing I'm looking at HIPAA compliant? Right now, go to whatever you need to do, any port in the storm. As David said, he's doing Zoom. That's fine. That's good to do. But in the future, if you think about when the pandemic's going to be over, the government's going to go back to HIPAA compliance. I can just tell you that's where things are going to be. So 6 months from now, you have to imagine I need to be on a HIPAA compliant version of whatever platform I'm using. And then I would think about the ease of use, both for you, for your staff, for your secretaries, for the psychologists, the doctors, the nurses, but then ease of use for your patient. I want a platform that's so easy that, you know, an 18-year-old can tap into it, that a 55-year-old can tap into it, that a 62-year-old can tap into it. I wanted somebody that can do it from their phone, from their computer. And then Doran's comment about make sure they realize that if they're walking around their phone, people can hear them. So when it comes to security and safety and talking about sensitive topics, you know, they probably want to go to a quiet space to have that visit. And I would ask them before I get started, you know, are you in a quiet space where we can talk? Can we share confidential information? And if they say, no, hey, I'm at work right now, then you know the filter you need to use when you're talking to your patient. Optional telepsychiatry features. So this is a slide I put together of things that I would think about with any of them. First of all, do they have a virtual waiting room? I'm a big fan of that. You don't want a platform where you can only see one patient at a time and they can't get in there until you're done with the patient before them. We all run long, we all run short. It's nice to have a virtual waiting room. So at one point today, I had one patient who queued in about 30 minutes early. I had another patient who queued in right on time, and another patient who queued in partway through that first patient's visit. So I had one person I was seeing and two people in my waiting room at one point. So the virtual waiting room, I think, is a very nice thing, and I'd like for that to be a customizable waiting room. I'll just have to say that's something I've really found very nice. I'm a big fan of various versions of file share. And so, as you know, as we heard, there's various ways to file. You can tap and do file share. You can have a whiteboard. There's different ways. Think about group meetings. My therapists have really become a fan of telemedicine because it's very easy to have family meetings. They can bring in a dad who lives in Colorado. They can leave a mom who lives in St. Louis. They can bring a teacher in who's in St. Charles, and they can bring the kid in a visit. So it's very easy to have group visits where you bring in multiple people. One of my favorite stories, and David, I think, heard this on Monday night. We had our other talk. I had a visit in a family's home. It's a young boy who has ADHD plus Asperger's. I started with the mom, and the boy didn't want to come out, and he built a big fort in his house. And this fort was blankets and sheets, and they were over chairs. And I said, Mom, I said, let me talk to Ross in his fort. And she goes, okay. And she slid the computer in there. And I had this lovely session talking to this young man about, you know, Ross, I love forts. This is cool. Tell me what you did. How are you doing during all this? How are you doing with your emotions? How are you doing with frustration? And he goes, you know, I did really good the first 2 days, but then the third day I blew up and I lost it, Dr. Mattingly. Like, what happened? He goes, you know, I had this thought before I thought about it, though. I just got angry and I blew up and I got frustrated. And we talked about thoughts becoming actions, becoming emotions, becoming actions. You have to pause with the thought and let it be a thought before it becomes an emotion. We had this lovely 20-minute session between him and his mom. And so these group meetings, in all kinds of unusual ways, telemedicine lets you have group meetings. It's going to let us be a part of IEPs. I've been reluctant in my 27 years in practice to be a part of an IEP meeting because it means taking a half day off work to drive to a school. But now they could Zoom me in, or they could Doxy me in, or they could FaceTime me into an IEP meeting, and I could spend 15 minutes to give my advice on what I think might help this child who's struggling with whatever their mental health issue. Think about the video and audio quality. I would go online both as the consumer, so your patient, and as you, and take a look on both ends. So take a computer and take a look at it and see what the video quality is. Have your wife or your secretary get in and take a look at it, because we found that there are glitches. One of the things I've learned, for example, I was afraid to go from standard definition video to high definition video because I was afraid to take too much bandwidth. I get much better visits with the high definition. I get less pauses, glitches. It's better on all ends for my patients. Some of the platforms have virtual scheduling. We are not using that right now, but I could see using it in the future, where you have a virtual scheduler. Your patient goes in, they say, when do we have visits available? They just pop their name in, they pay their copay or they pay their fee, and they're there on your calendar, and boom, you pop them in. And then some of the telepsychiatry groups allow you to pay right there when you sign up for your visit. So for example, with Doxy, it's called Stripe. With some, it's called Venmo, but it's a way that they just swipe their credit card. And let's say you're a cash-only practice and the follow-up visit's 100 or 150 bucks. Boom, they swipe their credit card. When you see them, you know they've paid their visit. They come on in. In our case, it's for copays. We're right now having a secretary call our patients for copays and verify their insurance. But I could see going to a world in the future where they just swipe their credit card. It's usually a 1 to 1.5% credit fee, which is the same we charge for a credit fee in our office anyway with MasterCard or Visa. And so that's a really nice thing for people that want to decrease office staff. Patients pay as they go in. Okay, let's think about some of the challenges of COVID and maybe where telepsychiatry could help to champion these challenges. Most schools are going to be closed for greater than 6 months. This will be a period of time, this will be a group of children, a cohort of children that we're going to follow for years to say, what's the impact of not having structure, not having school, not having traditional school for 6 months? So what do we know as far as, and I've done a lot of lectures lately about at-home teaching, at-home education, parents as teachers. Daily structure, the school day is structured on purpose. Wake up at a certain time, have breakfast, then start the day. You want a daily check-off list. Check off the things as you accomplish them instead of a checklist. And one of my parents taught me this. It's a parent with ADHD, has 2 kids with ADHD. She goes, Dr. Mattingly, I used to call it a checklist. It was like the drudgery and all the things they had to do was like chores. Now we call it a checkoff list. And every time they get something done, it's an accomplishment. We give each other a high five. I blow a whistle, I do something fun. Every time they get a subject done, it's a positive affirmation. We start with the preferred subject. Start with the preferred subject so they're looking forward to it, and then work your way in chunks to the hardest subject around 10:30 to 11 o'clock when concentration tends to start peaking for our kids with ADHD. If you start with an overwhelming subject, it can doom the day. If you end with an overwhelming subject, you can just end the day with frustration. So start with a preferred subject, something they're good at, they can look forward to it, and then work your day forward. Positive reinforcement, ratio of 5 to 1. We know our kids with ADHD do better with positive reinforcement versus negative reinforcement, and especially for parents with ADHD. It's easy to get frustrated. Next thing you know, all they're doing is negative. They're blowing up, they're yelling. Don't forget the importance of exercise. Exercise is a required class for our kids on purpose, ADHD kids in particular. Get up and kick a ball, throw a pillow, do jumping jacks, run around the house, go outside in the backyard, jump rope, do whatever it is, but 30 minutes a day of exercise. And then finally, modeling behavior. If you as a parent run around with your hair on fire, your kids will have their hair on fire. If you as a parent get stressed and raise your voice and yell, your kids are going to get stressed and they're likely to yell. If you approach your kids from a sense of calmness, from a sense of peace, happiness, affirmation, your kids will tend to reflect that back to you.
You know, Greg, I'm getting input from a number of people here, and Lawrence Jerome says that one of the advantages he finds with telepsychiatry is that you get to see the pets in the house. They introduce you to the dog, the cat, and you get a whole nother look inside somebody's world. And it's interesting because, you know, the patients come to my office, and now I have the opportunity to go to their house.
Yeah, I agree. So I've seen more kids and adults with dogs, cats. You know, you get to be a part of their life and a part of their family in a way that we haven't gotten to in the past. I can tell you, people love that. They love getting to, when they know you care about them and they get to share their life with you. I think it's been really enduring, and it's been interesting. I was seeing a very high functioning business executive, David, today, and all of a sudden I saw a cat tail flicking in and out of the camera. And sure enough, you know, it was her cat walking around, and we had never talked about her even having a pet. And she was talking about anxiety and ADHD and, you know, how her job has changed and financially. And next thing you know, we had this really holistic session talking about the things in her life that calm her, talking about waking up every morning and have an affirmation where she thinks of the things that she's thankful for, that she's proud of, and the things that give her peace. And so once again, I think that's a very touching way. So yeah, thank you for the physician that brought that up. Let's talk about some of the challenges of at-home learning. Studies have shown that lower socioeconomic children lose pace over the summer. And there are numerous studies all around the world that have shown that children from lower socioeconomic classes, they fall back academically more than kids from more privileged academic backgrounds. And that losing pace is cumulative from one summer to another. So they have more slippage cognitively as far as academic performance. And so maybe the kid who comes from a higher education background, he gets to go to summer camps, he's got intact families. And so over the summer, he progresses a month or two academically, whereas the kid from a lower socioeconomic falls back 2 or 3 months. It's over 3 years, what you find is, all of a sudden, instead of having a 2-month gap between performance, those kids now after 3 years, it's 2 plus 2 plus 2, it winds up being a 6-month gap in performance, where all of a sudden the one group is performing dramatically less than the other group. Those losses are cumulative over the years. What we also know is it's not just cognitive issues, but it's emotional issues and physical issues. Children with ADHD and children from low socioeconomic classes gain more weight over the summer. There was an article just written in Obesity talking about that summertime with more screen time and less structured activity for those children that are at risk and are ADHD children coming from lower socioeconomic are especially at risk. They gain more weight, and that weight gain is cumulative from one year to the next. So one summer they gain 5 to 10 pounds, the next summer they gain 5 to 10 pounds, and next thing you know, 3 years later, they're 25 pounds heavier than they should be. So they're not just battling lower socioeconomic status, they're not just battling cognitive challenges and ADHD, now they're battling physical challenges on top of it. And especially knowing our kids with ADHD tend to be impulsive eaters. Once again, this will be a cohort that we all need to think about. Nobody knows the effects of a 6 to 8 month break. And some people are talking about a 6 to 12 month break as we stagger next fall. So this is going to be a period of time where we've had 2 to 3 months breaks over the summer. Nobody's had a 6-month break. So there was an article published in JAMA Pediatrics just last week, David, that talks about, for healthy development's sake, it's time to mainstream summer. How do we help to give our kids more structure this summer to help compensate that? And especially the kids who have struggles to begin with. Kids with developmental disabilities, kids with ADHD, kids with ADHD plus, kids from broken homes. How do we help to give them structure, role models, positive affirmation to help compensate for this in a way that we've never really thought about all that much in the past? Here's some resources. We talk about screen time. This is from AAP and CHAD. And they say, you know, screen time doesn't cause ADHD, but we know that it can exacerbate ADHD symptoms. And what are the recommendations from AAP and CHAD? From birth to 18 months, try to limit digital media use. From 2 years to 5 years, 1 hour per day. And from 6 years older, for children, they recommend 2 hours per day. So one of my fears is parents will start using screen time, video time, Facebook, FaceTime is the babysitter. That's not going to accomplish healthy development, cognitively or emotionally, and in particular, emotional development for our patients. Some resources I put together, and once again, this came from the APA Telepsychiatry Toolbook. This is a slide that you can take and keep when we download it to ADHD in adults. This is something you can give to your patients who are doing telepsychiatry before the day of your appointment. Identify a private location, as Dr. Almagar said. Check your technology, make sure it's going to work. Organize billing details. If you have to pay a copay, pay in advance, know if you need to. Prepare your thoughts, take a note. What is it we want to think about? On the day of your appointment, get ready for your video session. So get ready 15 minutes ahead. Don't come rushing in, don't be late, get ready. Sit down in a calm environment, be ready, be free of distractions, especially for ADHD. Have some paper and a pencil. You may want to take some notes. You may want to write down a website. So have paper and pencil, and then start your appointment. Sign in a few minutes before, pop into the waiting room. If you have other questions, this link, which goes once again to the APA website, will talk to your patients about things that they should do when it comes to telemedicine. So this is a resource once again for you and for your patients. Centers for Parents Information. This is put on by the Office of Special Education here in the United States. I've got the link embedded in the slide. It'll take you right over to it, and it has all different types of resources, resources for parents, resources for clinicians. It's a wonderful website. And one of the things I love about this website, David, and I think we talked about this the other day, it has a listing of webinars that are free to the public. Any parent out there, any adult with ADHD, any parent of a child with ADHD can go to these. How do I do a better job parenting? How do I use positive parenting? You know, things aren't working, what could I do different? I'm looking forward to this, and I'm thinking that my kid may have ADHD and I didn't think about it before. How has COVID changed things? How are children around the world coping with COVID, the emotional stress of that? A virtual roundtable where a group of parents and parents educators talk about it. So each week, this is a rolling agenda of free educational videos that families can log on to. So I love this website. It's become one of the things I have learned during the COVID pandemic. APSARD. Let me once again, I've got a link on here for everybody. This is our American Professional Society of ADHD and Related Disorders. David is on the board of directors. He's a wonderful educator, a great clinician. I've known David now for 25 plus years. He and I both have the privilege of serving on the board. For anybody that would like to join, this is an open organization. We're welcoming members who have an interest in ADHD, who are clinicians, educators, researchers. Come and join us. The link is right there. And what we've really tried to do with APSARD is increase the number of things that we can do for our members. Blogs that talk about treating ADHD in the time of COVID. APSARD members in the news, the difference between ADHD and depression, ADHD bipolar, different rating scales. All of those have now been embedded in the APSARD website, trying to give our members increased resources. This is some guidance that just came out in Lancet last week, and this is by our European colleagues. So the European ADHD Consortium came out with ADHD management during the COVID pandemic as far as looking at things that happen in France, Germany, Italy, England. And they have a bunch of guidelines that are very similar to ours. It's published in Lancet, Child and Adolescent Public Health. But they talk about some of the same things I talked about when it talks to being a parent educator. Stay positive. Make sure all family members know what's expected. Use things chunking. Promote better behavior. Try to limit conflicts. So very common sense things, but sometimes common sense makes the most sense, and especially during these times. And once again, this link has a link to their paper, which is a great paper that's open access to anyone that wants to look at it. Here's something, another resource for each of you. This is something to give to your families. When we start thinking about next fall, I've seen things in my kids that I think need extra help. Here's what I've seen that helps. So the difference between an IEP versus a 504 plan. What are things that you can think about? What are the accommodations you get? What does it mean for your family? What does it mean for your child? What does it mean for the school? What does it mean they're mandated to do? And so this is a great resource about how do you create an IEP? How do you create a 504 plan? And what are things you want to know when you go into? And down at the bottom, it tells you who pays for it. And so it tells you, the school district pays for it. Why would a school district maybe push you one version versus another? So it helps you to understand kind of why the different pros and cons of each of these two plans as far as active interventions for a child or an adult when we talk about accommodations. The next couple of slides are some things that I have been using with my patients when I talk about doing more therapy, David. I've done more therapy once again in the last 6 weeks than I've done probably in 2 years. This is something I'm doing daily with multiple patients. I did it with a number of just children and adults today. Grounding. It's an anxiety technique that helps anxiety. I use it in the middle of the night if I wake up and I can't sleep. It helps with people that have trauma. It helps people under increased stress. And basically, it's guided meditation. It's mindfulness. You start with 5 things that you can see. So 5 images in your brain, and you have to stop and pause and see each of them. So my house on a snowy day, a beautiful sunset, walking my dogs in my neighborhood, and each of those images I think of in my brain. I then pause and I think of 4 things I can hear. The sound of rain, the sound of wind in the trees, the sound of the fan. I then think of 3 things I can touch and feel, and I make myself feel them. I think of the touch of the sheets. I think of the touch of rain. I think of the touch of a shower. 2 things you can smell, and for me, all the other images change. They depend on where I am and what's going on. My 2 things that I smell that always come to my mind, the smell of the air before the rain, the smell of coffee in the morning, and then finally 1 thing you can taste. And during this time of increased stress, this has been a wonderful technique that, certainly I didn't invent this. This has been around for decades, but it's been something I've been using daily with my patients. If I wake up in the middle of the night and can't shut my brain off, this is what I do to help turn my brain back off so I can fall asleep. Sleep links. This is a link to each of you that you can do with your patients. Give it to them if you want to. These are links that go right to YouTube websites or others that are free where you can listen to raindrops. You can listen to ocean waves. You can listen to a river storm. You can listen to white noise. You can listen to celestial white noise, which is kind of a star kind of thing. Office noise. So these are sounds you can listen to in the office. It's interesting. National Public Radio, David, on Monday said that people are having a hard time studying and working from their home because they're used to certain background noise. And so they came up with a series of various noises you can hear. And let's see if we'll go to it. If I back up one, ancient library. Is the sound of a library? Well, that's not what we wanted. It'll skip it. It'll skip it in a second and go to it. But it's the sound of a library with a fire running in the background. And so each of these, once you get past the ad they have at the beginning, it's like 10 hours of listening to the sound of raindrops with a fireplace. Office ambience, the one called Calm Office. You can actually tune up and down different sounds. You can tune up the sound of a typewriter, people talking in the background, a coffee cup that clinks every once in a while, because we found that our patients with ADHD get used to certain background noises and they have a hard time sometimes concentrating without it. Okay, a few last resources for you guys, then we'll go to questions. There was a really innovative program that a psychologist at University of Nebraska, and he works with our National Pandemic Center that's at University of Nebraska. And so they get the worst of the worst infections. They get the person in the bubble who comes in with a horrible infection, Ebola, the SARS outbreak in 2008, and now they got the first 20 really horribly contagious COVID patients that came in during this epidemic. And what they learned from prior outbreaks is it wasn't just physical consequences, but many of these people left with PTSD, anxiety, depression, that being quarantined and locked in and not knowing if you're going to survive had horrible emotional consequences. So they decided during this pandemic to have the patients start with the day with a virtual town hall. So the virtual town hall was everybody starts, these 20 people that were in quarantine in their own glass bubbles. They start the day with, what do we know factually that's going on right now with the pandemic? Let's share information. Here's what we know. Here's what's being researched. Here's where we are. How's everybody coping? How's everybody doing in each of your different containment areas? What have you all learned that's been helpful to get you through this? And then everybody got to share ideas. I've learned that having Zoom dinners with my family makes a huge difference. I get to hear from my kids and talk to them about what's going on, and they get to share with me. Somebody else said, I took up, knitting again, and I hadn't done it here. Somebody else talked about it. You know, I've been playing Sudoku, and I've never learned this thing. My kids used to play it. But the ability to reach out to help somebody else, to share your idea to help somebody else, they found was incredibly healing. And then they spent the last 15 minutes of each hour doing a mindfulness exercise very similar to the grounding one I just did, where they spent time imaging things, mindfulness, meditation, helping with anxiety. Thus far, the rates of emotional distress, anxiety, PTSD, depression have been dramatically reduced by having this reaching out, this connection, helping each other, sharing information. I then borrowed from that our office sits on the front of a mental health hospital that's had 28 staff members get ill with COVID and 6 patients. Luckily, our clinic and our office, no one has gotten ill so far. But we start every day with the town hall in my office. How's everyone doing? Let's share the information of where we are. Right now, St. Louis is at the peak of the viral load. By next week, it looks like we're going to be getting better. How are we all doing here in the office? How are our patients doing? Let's share a story of where we've made a difference in a patient's life so that we all have a sense of purpose. And it's been an amazingly bonding thing for our staff to help them during this time. Telepsychiatry top tips. Consider an external camera. So I have a Logitech camera that costs about $70. It can mount on the top of my computer or it can mount on a tripod. It dramatically increases the quality of your video. So I would say, you know, it's worth it if you're going to do much telemedicine. Just go buy an inexpensive HD camera and use the HD version of it. Dramatically better. And we have all seen the person that looks like they're in a bubble. They look like they're down a hallway. It just looks terrible when you look at them. Their coloring is terrible. Those Logitech cameras make a big difference, and versions of those. Have a phone number for a backup. Sometimes the very best intentions don't work out with this. The person's cell phone is hiccuping on the visual, their computer's working, but the audio is not. Have a cell phone number for a backup. Place the camera slightly above the screen whenever possible, so that you want to be looking and making eye contact at your camera. Put it slightly above your screen. It'll give you better eye contact with your patients. It also keeps the angle of the camera from looking odd with your face. So that was a tip I learned a long time ago. Stack a book underneath your computer and then mount it at the top of your computer. Have it up just a little bit so it's not sitting below you when you look at it. Make eye contact. One of the mistakes you can make, and you can see it with people doing telemedicine, they're looking at their keyboard, they're not looking at their patient. Remember, the camera is the eyes of your patient's soul. Look into the camera. Look into the camera. If you have to sit down and type, if you sit down and write, that's okay. But look up at the camera, make eye contact, and then don't forget to engage. Don't forget to inspire hope. This is not just about scaring at a blank screen. It's about engaging with your patient, inspiring hope, using your voice, using your eye contact, using the inflection of your voice. Voice has never been more important. My take-home messages for us: HIPAA and the Ryan Haight Act have been waived during the COVID pandemic, so we can use non-HIPAA compliance, such as the basic version of Zoom, FaceTime, and the Ryan Haight Act allows us to do initial prescriptions for somebody with ADHD. We can see initial evaluations, kids coming back from college, things of that nature. Telepsychiatry allows for remote care. So I have used it in group homes for people that are in quarantine. I've used it for patients in residential treatment for chemical dependency plus ADHD. I have used it for all different types of versions with this. You can use it during crisis. I used it with a medical student who was at medical school who was having difficulty, has ADHD plus anxiety. It allows you to reach into people's homes for remote care, which has been wonderful during this time. It allows for amazing transitions. I am going to use telepsychiatry. I was a skeptic. I'll use it from this point forward as a hybrid in my practice. I will see all of my college students 2 to 4 weeks into their first semester of college. That's been a time they're at increased risk. I haven't had a good way to use that. Up until now, I see them back at their first fall break, but by then it's 2 to 2.5 months into the semester. But David, I'm going to automatically, all of my kids going off to college, I'll have a visit before they leave, but 2 to 4 weeks into it, I'm going to have a visit on, how are you doing? How are classes going? Are you getting to bed on time? What's your peer group like? Are you bonding? Are you taking your medicine? Summers. Many of our kids during the summers go to spend the summer with a divorced parent, a grandparent, summer camp. This allows us to care for patients during all of those transitions. And then relocation. Many of our adults with ADHD may get moved. They may have a temporary job assignment. My college student may have, an interim class that he's doing. He may have an internship somewhere. This allows you to continue with care. People that go on missionary service, this allows you to continue serving them. One of the nice things about telemedicine, and we have visits that are specifically coded for this, it allows really brief visits where you can check in with people. And I say, we're going to check in. Why don't, instead of a month or 2 months from now, I'm a little worried about you. I'm going to check in. I would like to see you in a week or two. I had 5 of those visits today. They were 5 to 10 minute visits. I put them in kind of in the middle of the day. I had them in a kind of a grouping together. And I said, you know, I'd just like you to check into the waiting room. I just want to see you. I want to see how you're doing. We just started you on this new medicine. I just started you on something for anxiety. I know you're not sleeping. I'd like to check on you in a week or two and have a brief visit and see how you're doing. And having people come to my office, that was something that was hard to do. And then finally, coordination of care for IEPs, consults, team meetings, all kinds of creative ways that we're going to use this in the future that we haven't been able to use physical visits in the past. So what I would like to say about telemedicine, telepsychiatry, in one form or another, this is going to be here to stay. We all knew this was coming in one version or another, but COVID has accelerated it, and it's all taught us to use it in ways that our patients come to appreciate. So at this point, I think we're going to send it over to questions. So David, questions from the audience. What can I help to answer for you?
Greg, that was just marvelous. Just a broad base of information, not only from the resources with the active links. I'm impressed with the active links and your internet speed connection wherever you are in the country. That was great. There have been several questions. One that hadn't really occurred to me, although it should have. Jake was asking about the suspension of medical practice across state lines. But what about the implications for the DEA restrictions? Are they still in place, or do they equally get suspended?
Yeah, so 1135 says that the DEA restriction should be lifted and there should be leniency in it unless somebody is doing something nefarious. So I think we're okay there. What's a little more tricky about that is that's federal guidance. We each have state B and DDs. And so that's a state issue. The states are supposed to, during the COVID pandemic, follow the 1135 waiver. And in my state, I think they've been okay with that. And Missouri's actually been a very tricky state on controlled substances. We're one of the most difficult. So I think we're okay with that. I think the 1135 waiver being lifted says, as long as you're doing things in good faith, as long as you're doing good things for continuity of care and for ongoing care of your patients, I think that is the recommendation right now. And I would really like to see that the 1135 waiver, as long as, once again, we're practicing in good faith. When you think about us being a global country, you know, if we have a student that goes to school at University of Florida or University of Texas, and I happen to be in St. Louis, that kid's going to benefit from me being able to continue to see them. So I think it makes good medical sense for our patients, but we'll have to see what happens in the future going forward after the pandemic's over.
Right. I just had a session today with a student of mine who's in Edinburgh, Scotland, and these sessions would not be possible without this kind of technology. Doran wants to know, though, with patients on medication, if we're not seeing them in our office, what do we do about monitoring blood pressure and pulse?
So Doran, that's a great question. So there's a lot of ways you can do that. So right now, a number of the medical platforms for eHealth actually have electronic blood pressure cuffs. And so I was just talking to one of my adults. He already had an electronic blood pressure cuff that was given to him from his internist because he has hypertension. That may be something in the future we lean towards. We may have electronic blood pressure cuffs where we can see somebody. They stick the cuff on. It's an appropriate size cuff for a child, an adolescent, or an adult, and we get, you know, a virtual heart rate and blood pressure. I don't have that mandated, but I could see a future where I think that's going to be the future we're going to be living in as we go ahead.
Right, but you mentioned on the talk the other night, you and I did, that in the light of not having these electronic blood pressure cuffs available, I often tell patients to get a blood pressure cuff and we'll check it before and after they're taking their medication and then create a log and then email me or send me those numbers. And so we can, do you do the same thing, I suppose?
Same kind of thing. Yep. So we've done all of the derivatives of that. So get a blood pressure cuff and take it. That's a little harder right now, but pharmacies are still open. They can drive through and get one. They're not that expensive. You know, so all of those versions of care, and I've actually consulted on 2 different clinical trials, one that's an NIH sponsored trial and one that's a pharmaceutical sponsored trial on how do we measure blood pressure virtually and look at having these types of telemed visits virtually for patients in clinical trials.
Right. So Mark asks a broad question, and that is, how do you go about supporting families that have multiple members with ADHD? Parents with ADHD, their kids are with ADHD, everybody's cooped up at home. I know you do this day in and day out. What suggestions do you have?
the suggestions are universal. The importance of exercise, the importance of affirmation, the importance of pausing and taking time and reacting and thinking through something before it becomes an emotion. And then once again, this is a challenging time for our families, but it's also a time where there can be a lot of reward if you do it right. And so, I have played more ping pong and thrown more footballs and watched more movies as a family. But every day I'm stressed about my clinic, I'm stressed about my office, I'm stressed about my patients. So it's a heightened period of stress, but if done well, it can be a really rewarding time. And I've really been reflecting that back to my patients. So my dad with ADHD, I'll say, Dad, your son's never needed you more. Think about the things you used to do and loved to do when he was your age. What'd you like to do? He goes, I used to like to throw a football around. My homework assignment is, I want you to take your kid outside in the backyard and throw a football with them every day. And I think you're going to see there's an amazing emotional thing that'll happen between the two of you that maybe right now with him cooped up in his room doing video games, you haven't noticed.
I wanted to address perhaps some business concerns. I've been looking at surveys. There's a primary care collaborative survey, and it said that 90% of the practices, and this is primary care, 90% of the practices saw a decrease in their volume. 57% said that less than half of their visits were now reimbursable. So there's a tremendous reduction in revenue. Many of these practices are laying off staff, furloughing staff, and so there's some really business economic considerations for those of us who are in private practice. I wonder if we could just highlight some of the benefits to consider moving to telepsych as not only the bridge over the COVID crisis, stay at home time, but anticipating what the business realities are going to be in the future. So to be more lucrative and flexible in the development and direction of private practice in the future.
Yep. So David, as you know, I'm part of a small private clinic. We have 4 doctors, we have 5 therapists, and we have a research team. Research for new patients has been shut down for the last 2 months. We still have ongoing patients in clinic visits. They have to come in. The only people we're seeing live in our office right now are people getting long-acting antipsychotic injections, people getting esketamine for depression, and people in research. Everybody else we've gone to telepsychiatry, and without telepsychiatry, we would not have been able to afford to keep our clinic open. We'd have had to lay off our staff, and there's been a lot of clinics across the country, as you said. There have been primary care clinics, psychiatric clinics, specialty clinics. The ophthalmology group down the street from us that we tend to refer our patients to have cataracts and things, they're closed right now. They laid all their staff off. Even the hospitals. My nurse I talked to, she goes, Dr. Mattingly, she goes, I'm getting about 30 hours a week. She goes, they're short shifting everybody because all of the surgeries that were elective have been canceled and the hospital's actually pretty empty. So, the COVID wards are full, but everything else in healthcare right now. And so I'm like David, we have a big fear. Mental health care will never be more needed as we come out of COVID. There's going to be an increased need for mental health care, but many of the small clinics will have been badly damaged by this.
Right. And so we should, in closing, let us just take a moment to highlight why telepsychiatry should be part of every mental health practice. And that is, in my experience now, my no-show rate is 10% of what it had been. So my occupancy in my schedule is higher. My patients are now on time. It was running about 25% of my patients a week were running late, which would back me up and put me under strain. You're also able to get collateral information and include multiple family members, which means that everyone is more attached to you in the patient-doctor relationship. And I'm sure we can go through a variety of others, but I would just like to encourage, and I'm sure, Greg, you would too, that this is not something to hold your breath and wait till it goes away. This will be the new frontier for psychiatry and mental health professionals. And if you're not on board, I can tell you there are large companies that are looking at this, that are buying up telepsych companies in the goal of referring their patients in-house for telepsychiatry and psychotherapy. Greg, your comment?
100% agree. And I think all of us will use this. One of the big things in ADHD for years has been transitions. The transition from one parent to another, the transition from high school to college, the transition to going to your first job and moving away. Telepsychiatry lets you bridge the gap for all of those transitions. So I think it's here to stay, and I think it's going to be something that's really going to be a meaningful advance for our patients with ADHD.
Excellent. I think with that, Jonathan, you're on board. So Jonathan is administrating the webinar. I think I will give my many thanks to Greg. I appreciate our friendship for 25 years. I don't know how that's possible given that I'm only 32, but that's wonderful relationship. And Greg, I appreciate you putting together the slide deck so quickly with just so many resources that have actually just developed over the last month. So kudos to you. Jonathan, you want to take control of the webinar?
Sure, thank you. I want to thank greatly both Greg Mattingly, MD from Washington University School of Medicine, and David Goodman, MD, Johns Hopkins University School of Medicine. This has been put on by APSARD, the American Professional Society of ADHD and Related Disorders, and if you'd like to join, we encourage that. And this is also sponsored by ADHDinadults.com. We have a lot of CME on our website and also Ask the Experts sessions, and we will be able to post both the webinars this week on the website for you to watch the replay and in certain cases download the slide set. I want to thank you all for being here today. We got a lot of comments throughout about how helpful this webinar has been and how helpful this information has been. We really hope this provides support for you as we go through this COVID transition. And I agree with both doctors when they say that this is the new normal. This is bringing about a whole new technology and use of technology that I think is going to stay with us for a long time. So it's a great time to adapt. Thank you very much both. Thank you for all our attendees. We look forward to seeing you again. Take care.
Take care, everybody.